Welcome to Dr Joe Unplugged. This podcast contains general information and is not in any way medical advice. So today I'm very pleased to be joined by Professor Martin Samy. Martin, welcome to the program and thanks for coming in.
Thank you for your time.
So we're going to get into some philosophical and medical discussions and try and solve all the world's problems. But before we do that, for people who might not be familiar with you, tell us a little bit about your background. And it's a fascinating and storied one, some of the different things you've been involved with and, you know, your travels around the world and ultimately landing in Perth.
Thank you very much. In fact, I actually started from Monash. I was a lecturer at Monash University in the Faculty of Business in Accounting and Finance. But then I moved on to work as a professor and at Leeds Beckett University in the UK. And I did my PhD from Monash, by the way. And I did a lot of research. Monash.
Yeah, but in what topic?
In social responsibility, effectiveness, basically. So I tried to measure the perceptions of effectiveness. Right. So when I went to the UK, I developed my niche in social responsibility, mainly corporate social responsibility. So I basically did a number of research with Shell, Niger Delta, with Primark, a lot of large corporations, with Apple. So I did a lot of research in that area, more into finance, effectiveness, efficiency, and its impact to social justice and equity. Mm-hmm. So basically my area of expertise in this area. I have done a number of research papers, done a lot of talks, and also currently, and have done in the past, I do philosophy degree students, PhD students in my area of expertise. Right. So I'm quite knowledgeable in the area of global reporting initiative, sustainable development goals, that Australia is signed up to the UN Charter, and where medical situation criteria is indicated there. So since I have done so many years of work in the UK, about 7-8 years ago, I retired early as a tenured professor and moved back to Australia. I still do a lot of research and teaching for PhD students and master's students for Catch Business School in France, University of Dasmascarine in Mauritius. I've got students at the City University of Birmingham in England. So currently I'm left with 4 students in different stages of their PhD studies, all involving social responsibility. Okay.
So you're supervising these PhD students as they do their PhD.
Correct. I supervise them.
All right, and they're from 4 universities scattered around the globe.
Correct. City University, Dasmascarine, you know. So they are, and I do a lot of nowadays with technology, you do a lot of WhatsApp, Google Meet, Zoom meetings, weekly and fortnightly, monthly, and then they submit their PhDs and they get the title of a doctor. Yeah. And that's what I do. Since coming to Australia, I established a group of medical practices with the philosophy of social justice and equity. I did it for my only daughter, my Princess Christabel, and I set this all up, and it has been a challenging times understanding the medical world in Australia and its challenges that I'm sure you're very familiar with.
Yes, I know there's challenges all around the world, and we've certainly not immune to them. The terms, and you mentioned it, and it's important. The term social justice seems to get bandied around quite a lot and seems to mean different things to different people. What is it? What's your understanding of it? Having actually studied the area rather than just putting your hand up as an activist.
Yeah. See, I'm not. I don't want to be called a.
No. So you've actually looked into the area, just not just getting out in the streets. You've actually studied it.
Correct. And I don't, hug the tree and all that stuff. But what I do is I try to practice social justice and equity. I mean, the key word is equity, fairness, giving everybody a fair go. So, like, for example, in primary care, following the Sustainable Development Goals, I'm quite keen to social democratic philosophical ideologies. That is to say that we should be accessible and affordable. So if you were to ask me how do I apply my philosophical mindset to what I do daily in my as a CEO of a medical group, is to apply this philosophy to be fair to people, to help people with mental health, with chronic care plans, to make sure they get the point of care when they need it, and to the best of society's ability to provide them. And I do that like bulk billing. It's one of those ethos I set on in my daily life.
Okay. Again, the concept of affordable when it comes to healthcare is also an interesting one, because to some people a Ferrari is affordable, and to some people a beat-up Hyundai is not affordable. And there's been, I entered medical practice a couple of years after Medicare was established in 1984 and celebrated its 40th birthday this year. And when it was started, it was this view that there should be access that was meant to be a basic insurance level, as sort of like a floor, not to cover everything for everyone. But I suppose the question sort of arises as to how... is it reasonable that if I'm a millionaire, that I don't have to pay anything towards my health care? And by the way, maybe I'm blocking a space that somebody who genuinely can't afford health care could use if I got out of the queue.
That's a very valid question. I mean, we are lucky in Australia, and I do agree. If I compare ourselves to England, where it's universal health care, the NHS system, it has a set of problems. Even let it be the king or queen or royalty, or even very influential rich people do access the NHS, regardless of their means at all. It's not means tested. Now, in Australia, we too have that Medicare. Medicare is effective in the sense that it gives doctors a chance to bulk bill. And many do. I mean, our Medicare rebate rate is about 80%, or slightly more than that, I believe. Medicare rebate rates. I mean, that's I know the figures.
The direct billing rates.
Correct.
Yes.
Direct bulk billing rates.
One important caveat on that is that's the percentage of services, not the percentage of people.
Correct. It's the services that they provide.
Yeah.
I fully agree. So 80% of the services is bulk billed. And I think that is the argument. Now we also have the issue about the government funding through strengthening Medicare grants to help practices to be able to bulk bill with the triple bulk billing incentives. They also have the urgent care clinics. Now, all this is done because of social justice and equity. So the Labour government has a duty to ensure, with the high rising cost of living, especially after the COVID, we have a lot of instances where a lot of people cannot even find rental accommodations. We have cost of living over the roof. So it is expensive. So we do not want the society to suffer later years because they're compromising health because they cannot afford out-of-pocket costs. And one of the biggest challenges we have got is the out-of-pocket cost. Somehow, there needs to be a balance. Frankly, I don't think you and I can resolve the problems in one session or in a decade. It would take another few decades before we find a solution to this problem. However, I have to decide. Now, I'm not, as in my practice, I'm not going to decide whether you are rich or poor. I don't think a doctor should be in a position to say, okay, I will bulk bill you because you told me you lost your job. Or, okay, I think you are driving a very small little car and you cannot afford the petrol. I don't think doctors are in that position to be financial gatekeepers. So how do we solve that problem?
It's an interesting point you raise, and there's been a view expressed, and I'm not necessarily agreeing or not agreeing with it, that the local doctor who knows the person will have a much better handle on their circumstances than some bureaucrat in Canberra. And the flip side of that one is also, and again, these are anecdotal tales, but they are genuine. I've heard enough of them over the years, of people rocking up to the doctor wanting, their travel medications because they're going business class to Europe and then expecting to be bulk billed. And that does sort of get in the craw of a lot of doctors as well. But I wanted to come back to a question, and you mentioned about the equity in the system. Is it working? In as much as does what we get, and particularly in terms of mental health and the outcomes, is what we get a reflection of what we're aiming to get?
Okay, that's interesting. Look at our crisis. I think I recently saw that we have got an epidemic of diabetes. A Senate report came out a few weeks ago, a few months ago. It's a bit of a interesting, situation that we are faced in. We got a mental health crisis. Now we have a lot of people who don't access primary care for mental health. Why? Because they cannot afford to spend the time, or the doctor to spend the time and get Medicare rebate, which is a bit lower than a doctor would expect. So there is this conundrum. And how do we resolve that? I think, if I'm not wrong, the government or St. John of God tried having mental health walk-in clinics. I don't know how successful that has been.
I'd be pretty surprised if they're particularly helpful, but I could stand corrected.
Yeah, even Headspace was a classic example that was not effective, found in a few last year's report that came out. Headspace wasn't effective financially as what the government has put into the coffers. So it is a question: what is equity? What is equality in our system? What is fair? And is fair means universal healthcare does not mean it is free. Universal healthcare, people misunderstand. Just like it shouldn't be considered free. It has to be affordable. It has to be accessible. That's the point. Even as a bulk billing practice, there are many things that we do not bulk bill. Like if a person were to come for filling up a form, a commercial driving license, they have to pay for it. Medicare does not cover. So I think sometimes a system like that, like Medicare rebates, can be tightened. I'm just thinking aloud, tightened to avoid certain aspects. Should we have, just to your point earlier, a rich person may not be given a higher rebate than a poor person? I don't know whether that's possible. So you could have a structured income-tested Medicare rebates? I don't know.
That's interesting because virtually every other form of government assistance does have some degree of means testing. You don't get the age pension if you have millions of dollars in the bank. And, fair enough. So Medicare is the only form, and it's not a welfare system, but the only form of government program that doesn't have some form of means testing. And I gather before Medicare was introduced, the original Medibank had something along those lines. Again, 50 years ago, I could stand corrected. But you're right, nothing's free. It's paid for by somebody. And in simplest terms, there's two possibilities. It's either the person consuming the service or somebody else. The variation on that is it can be a bit of both.
Correct. It has to be a balance. There is no one size fits all. We have a unique problem. So let's say, for example, we got a high level of chronic cases. Diabetes is a problem. Somehow we have to find a solution where we try to manage that situation at a primary care level, make it much more affordable so that in the long run, there's less burden to society.
And I mean, part of the issue, in my opinion, is that our system is still largely configured on an acute care model, and the top of the system is the tertiary hospital, and they're horrendously expensive. High technology. There's absolutely a role for it. If you get run over by a steamroller, you need to be in a tertiary hospital. Same if you're having cardiac surgery. But the emphasis has always seemed to be at that top end rather than the bottom end. There's a lot of lip service paid to primary care, and this is not just general practice. It includes, physios and, nurse practitioners and pharmacy. There's a lot of lip service about primary care and a lot of lip service about what can we do to prevent complications from diabetes. But there's nothing other than lip service that I see from governments.
I agree. And I think we need to understand that the government does spend a lot of their GDP on healthcare costs. It's rising, okay? It's high. Healthcare cost is very expensive. Now, where do you use that cost to which area that is most in need is a challenge in itself.
Absolutely.
I mean, we have two issues here, diabetes and mental health crisis. Now, perhaps the government should put in more money into mental health crisis. How do we resolve that problem? Why is a lot of the societies unable to get that help that they need? That's a big question mark, you see.
And I'm to be convinced that more money of itself is always the answer. And you mentioned about Headspace, and a lot of money has been thrown at that. One looks at the USA, which spends double the amount of GDP on its health system than any other country. I don't see that they're living longer. I mean, their outcomes are actually poorer, but it's not for lack of money. They're just, when one considers that it's 18 or what % of GDP, and you look at the size of the American GDP compared to other countries, and if they were living twice as long as all the rest of us, we'd probably say, yeah, that's the answer.
Works.
But not only isn't it that, it's actually worse. So that then comes to not just, yes, we'll throw more money at the problem, it's actually using the money in an effective way. And that's where, and look, I don't think Australia's unique with this. It's a problem right around the world, but there doesn't seem to be much effective spending.
That's the word, effectiveness. And this has been toyed around a lot. We target spending, and this is the problem with healthcare costs. We do have a unique problem in Australia because we've got Aboriginals' health to worry about. And it's a big issue as well. How do we look after the Aboriginal, our First Nations? So these are all some of the things that the government has to look at. Now, we also need to see whether we are funding the primary care sufficiently enough for it to survive. And that is in itself a challenge in itself. And as a small practice owner of 3 practices, I do have my challenges. How long can I sustain the quality of care and continue doing what I love to do or what my doctors love to do? And I think it's a problem across the board.
Well, this country, and it's not unique, has a shortage of doctors, and that shortage is increasing. I read a figure out of the USA projecting a shortfall over the next decade, and I think this was last year, was up to 2033, of 128,000 doctors. That's what they're projecting was the shortfall. That's nearly equivalent to the entire Australian workforce, and that's just the gap. New Zealand, I read in one of the medical news wires, they're in a worse situation than Australia. Similar, they've also got an ageing workforce, and they're relying heavily on doctors that they're bringing in from other countries. And in Australia, it's the same. We're reliant on international medical graduates, which at one level is fine, but it says, well, why aren't we training our own? And by the way, at a much higher philosophical level, should developed countries such as Australia, New Zealand, UK, Ireland, USA, Canada, should we be importing doctors from countries where the health of the population is not as good, where the people don't live as long, and the numbers of doctors to the population is even lower than it is here? Notwithstanding, I understand why doctors may want to move and seek a better life for their families.
Yeah, this is what we call brain drain. Now look at, for the last decade in Australia, we had a lot of English doctors. A lot of English doctors do not like the NHS for their lifestyle, for their income levels. They come to Australia. Now, that is the reason. Yes, maybe they may come for a beautiful sunshine and they hate the cold. I can tell you for one thing for sure, I hate the cold myself. I was so glad to come to Perth. The only thing is I still can't get over Christmas with 35 degrees. When I'm used to looking out for
Christmas.
Yes, I'm used to looking for white Christmas. And I come to Australia and I said, bloody hell, it's 35 degrees and it's hot like hell, and it's a bit difficult to adapt to it, and I do miss that.
Yeah.
But a lot of doctors come for a lifestyle to Australia. We have to be, the income must be able to attract, and we are attractive to doctors. If not, we won't be getting so much of IMGs from third world countries, from developed countries.
Yeah.
We have doctors from Ireland, from England, and we also got doctors from Malaysia, India, and also many doctors are coming here to have a better lifestyle.
Yes.
But I agree with you. Should we rely on that for the long term? Definitely not. We should have homegrown doctors. Why are we not having more doctors graduating?
Yeah.
That is a problem in itself.
And the next question after that, so about 20 years ago, I think in around about 03-04, Tony Abbott was the then health minister. They doubled the number of undergraduate places for doctors. They opened or announced the opening of new medical schools, increased the numbers in existing medical schools, and those numbers hadn't been affected previously for about 30 or 40 years or so. And a decade later, some of these people, are graduating and coming through. What we find in primary care is that, and you might be familiar with this, the RACGP training program has struggled to fill all its positions. So at some point, years ago, in the order of 50% of graduating doctors would look at going into general practice, and the other 50 into different specialties. That makes some sense because we need more primary care than the others. Now that number is 15. And it just raises the question as to why has it become so unattractive, and what needs to be done to address that. And I think, and you and I might disagree on this, I think part of the unattractiveness is that they look at their colleagues who go off and become orthopaedic surgeons or gastroenterologists or ophthalmologists. They've done the same amount of work, the same amount of training, put in the same number of hours, and they're earning multiples. And it's not saying money is everything, but I think this current generation sort of look and think, well, what are my talents worth? And if my talents is worth X here and 5X over there, I might go to the 5X because I'm worth it.
And that's very true. I mean, I did a bit of a look at some weeks ago about the top 10 earners around the world, and Australia is up there. Okay, our top 10 earners are anaesthetists, surgeons, even GPs are ranked number 6th with a taxable income of about 255,000. Now we are up there. UK, I think doctors are number 9, if I'm not wrong, the last time I saw. European countries are around the same. Ireland is quite high. Doctors there earn good money in Ireland, according to this statistic that I looked at. So there is a disparity in that area. So I think as a government, they should look and see and reward the doctors in order to be attractive profession, enough for them to sustain a good quality of life. And that applies to everybody as well. I think that's an important part. I personally do not think it's because of money. I personally think it's not of money. Figures show otherwise.
Look, that is true. It's a part of the issue, but it's not the sole issue. And that partly is why there's difficulties getting doctors into rural areas. There's often a lot of money being thrown at them, but they still don't go.
Exactly. And even the triple bulk billing incentive, they give other incentives for the doctor stream under the WEEP program. So money is thrown, but it's not money that attracts the doctors. So it's not money driven. I believe also, of course, the length of study, the difficulties in going through exams, and I think that does play a part. So why then not many doctors being trained could be a reason. I don't know the solution to that, of course. It's a problem that every country faces. Hence, having said that, Remember, in Queensland, they allowed UTIs to be treated by pharmacists. I know there's been a lot of a challenge with that, and a lot of criticism on that policy. Now we have also extend nurse practitioners. Maybe nurse practitioners could be an approach. I remember very vividly about 15 years ago when I was in the UK, and if I wanted to call my local practice and I want to see a doctor, I get seen by a nurse practitioner who prescribed antibiotics to me. I didn't get to see a doctor. So this was 15 years ago in the UK. So perhaps maybe we should open up the scope of practice, train more nurse practitioners, and there's also being toyed around the word AP, Assisted Associate Physicians, to relieve the pressures of the system, the medical world. It's better to be seen, I would argue, okay, and you may not agree with me, it's better to be seen by a nurse practitioner rather than not being able to see a doctor for weeks.
Look, I think that's probably right with one rider, and again, doctors can get it wrong too, but getting the wrong diagnosis and going down the wrong path, and I'm not saying it would happen, but can be worse than waiting a bit longer. Certainly having, and I'm a great believer in delegation personally, so the ability to send tasks or different roles to a physician assistant or to a nurse, I think is a great idea. Equally, again, and I'm generally of the view that government is generally the problem, not the solution, the system under Medicare basically says that there's no, if somebody just comes and sees a nurse and doesn't see me, then nobody gets paid. Not me, not the nurse, not anybody. So the system basically forces me to have to see people who perhaps could be seen by a nurse or physician assistant. But if you're running a practice and you're having to employ these people, unless you're deciding you're now going to run a charity, it doesn't work.
I agree. I think I give an example. I remembered my daughter used to tell me when she was in England, she never did cervical screening. It was done by the nurse. When she came here, she had to do it so that she would get Medicare rebate for it.
There you go.
So that was a classic example. And maybe that's why, perhaps the Medicare rebate should change. We should allow more flexibility, maybe like what we discussed, a structured approach based on income tested. If you are retired, rich, let's say a CEO of Woolies, and I'm just giving an example, and you left the profession, you're a multimillionaire, retired playing golf, perhaps you shouldn't be getting Medicare rebate. I shouldn't be saying this, but maybe you should not be entitled for Medicare rebate.
At very least be contributing towards the cost of your health.
Precisely. I don't know. I mean, these are some things that I think if you want to balance a system, make it more equitable, fair, these are some things that the government should consider. I mean, I'm sure many of us in the medical world may not ever receive a pension from the Australian government because it's income and asset tested. Perhaps we should not even get a Medicare rebate. I'm not saying that, but I've just mentioned that.
I think it's more that, I can contribute, so it's not everything is paid for. I make some form of contribution, and maybe having routine surgery in a public hospital should be means tested, that if you can afford to get it done in a private hospital and you can afford private insurance, then that's what you should be doing. You're not being denied care, but that frees up a space for somebody who can't afford it, and
the public system will not be clogged. And like you said, I mean, we used to have, I think, private health fund used to be extended to primary, secondary care. Now you have to be only tertiary care. So that limitation creates a burden. So perhaps if I can afford to see a private cardiologist, and I can use my private health fund, that could be a good thing, because then the public system can cater for those who really cannot afford it.
The other issue, and I'd be interested in your take on this, Martin, that I've spoken about over years, in fact, when I wrote a book many years ago about this, is that essentially we talk about a health system, but it's a disease system. We don't actually have a health system. And one of the reasons we know that is, we've got more hospital beds. Isn't that good? Well, a health system should actually say, well, we've been able to reduce the number of hospital beds because they're sitting there empty. So we actually have a disease system, and we're the proverbial ambulance at the bottom of the cliff rather than the, watch your step at the top of the cliff. What sort of approaches can be taken to get people to better manage their own health? Because so much of the disease burden in Western society, 75 to 80% of it, is lifestyle related. It's not something you catch. It is and it's not. Again, not criticising people, doesn't make them good or bad people, but it does say that a lot of it is more avoidable and preventable than is given airplay.
I'll give you a classic example. A few weeks ago, I was at a Senate hearing on menopause and perimenopause. And I had with me Dr. Carr and Dr. Christabel Samy. And we presented a paper that we wrote. And I believe in Medical Forum, it was a small little article came out. Now, that's a classic example. During the course of that research, I was very surprised. There is so much of information about menopause and perimenopause symptoms and an approach to take on health pathways. Mm-hmm. And I was very surprised that the public is not aware of that. I still hear complaints from patients who says, my doctor doesn't understand. He dismisses my symptoms. And that is because it is not, perhaps information is not trickling down to the public. That is, the public the health pathways is a fantastic resource for anybody to find out what's happening. Rather than Google, you can go to health pathways and identify issues and what to do, what to expect. And then when you go to your doctor, say, well, I saw the health pathways, I'm getting hot flush, and could it be because of my menopause or something like that? And that would help the doctor to identify, and also the person would then be able to appreciate the problem that they have got and how to manage it themselves.
Yes.
Like go and see a pharmacist, or even perhaps say, perhaps I do not have to see a doctor, but can I just chat with the nurse?
I think that's very, very valid. I think there's a lot to be said for various awareness campaigns that have been run over the years, but it also sends a bit of a message that any bodily symptom that you get, and I remember in med school we were told that on any given day 90-something +% of people could have some form of bodily symptom that could lead them to the doctor, but most of the time they go, I've got a bit of a headache. Well, I don't have to go to the doctor. I can take 2 paracetamol. But we've almost reached a stage where nobody can consider themselves healthy unless they've been told that their sort of sore toe isn't cancer, and disempowered in that the idea, well, look, maybe there are some changes that I can make and I don't have to do it under medical advice. Have we medicalised life too much?
I agree. I think we need to empower people, make them aware. I just ask myself, how many people on the street, if not in the medical world, have you heard of health pathways? Have you visited that site? There's another one recently, Health Link or something like that. I need to check it there. And it's a fantastic resource for anybody to find out. It's a government resource. Right. And that has got vital information. Perhaps that would take the burden off the public system. But having said that, also, I'm quite impressed. Very happy with, in a way, okay, although I don't think clinically you would agree with me, is with the telehealth. Now, there are so many instant scripts, pilot. I've lost count of how many technology-driven medical. So you can just pick up the phone or go onto the computer and get help. So that is also releasing the burden on the primary care. So some of my patients in my practice say that, oh, you are closed on the weekend. I got the script from Instant Scripts, or they've got it from Pilot or somewhere. That works as well. Yeah. So I think that also releases the pressure on medical health system within the country.
I think telehealth is... It's a tool, and it can be used for better or for worse. yeah, there are certainly restrictions. I remember in the early days back in 2020, and we were still seeing people, but somebody went, "Oh, look, I think I've got a sore knee." Well, okay, I can't really do a lot for your knee unless I can actually examine it, and I can't do that on the phone. If it's a repeat script for, I don't know, even a blood pressure medication, I suppose if you've done your blood pressure at home, that's fine. So I think it does have a role. Interestingly, the medical regulator is now trying to crack down on telehealth. Having let the genie out of the bottle, as it were, they're now trying to shove it back in. I don't think they can.
Yeah, it's very hard. But I think one of the things that I concerns about that telehealth is that there's no preventative care. You just simply cannot be going on instant scripts and getting metformin for the next 6 months, 1 year. You need to see a doctor, get the blood test results, check your HbA1c, look at your lifestyle. And those are all preventative medicine. And I think in one sense, with my Medicare that the government started about a year ago, is brilliant because you avoid having 2-3 GP or practices that you visit. You have one GP practice and they know everything about you. And if there is more support to the primary care to do after-hours teleconsults, that would be a game changer. So personally, I believe it would be better for medical practice to do after-hours teleconsult than an outside source.
Yeah.
Having said that as well, the government has invested millions of dollars on digital technology. So we all have, any medical professional can easily access my health records. So we can see which doctor you visited, what medication you were prescribed, even if you were dispensed that medication, including any imaging results and all that. So with digital technology, perhaps telehealth companies like Instant Scripts and all of them would be able to better manage. I'm thinking so. I'm not so sure because I'm not a clinician. So you would know better.
My health record has some, but fairly limited usages. I sometimes marvel at the fact that I can go to any country in the world and I have my, not that people use cash that much anymore, but I can go to a teller machine and take money out of my account anywhere in the world with that card, and all of these different banking systems talk to one another. There is, and I'm not a techo, right, Martin, but the term interoperability comes up, that the health system has no interoperability, that if you do go to a practice down the road, there's nothing in my other than my health record, which has fairly limited information, no connection between me, physio, another doctor, specialist. They're all in their separate little silos, and there is no connection, whereas all these banks seem to be able to connect to one another.
That is one of the biggest criticism I read. I read a paper recently on the challenges of the Medicare system. One of the biggest issue is our fragmentation of our medical system. We are highly fragmented. The physio and the practice do not talk. Now, one of the things that the strengthening Medicare initiatives by the government is to create this multidisciplinary support. So they are hopefully funding through the workforce incentive payment to practices to work with multidisciplinary teams like podiatrists, physios, exercise fees, dietitians and all that. So there is an incentive for practices to receive the funding by this arrangement. So personally, as a practice, I have a lot of MOUs. I also create room space for my physios, for my dietitian. I get funded by the government to help me to fund this program. And that is helpful because one of the things that I do in our practice is we do case conferences. So Christabel, who's our medical director, every fortnight, she has case conferences where the physios attend, the dietitian attend, the psychologists attend, and there is an intercollegial team that looks at the patient holistically. So these are some things, to be honest with you. I have read the white paper. It is coming. And I think it's a way forward, as you mentioned.
Be interesting to see how that does play out, because the predecessor to my Medicare, which was healthcare homes, back in 2017, I think, Malcolm Turnbull launched it in a blaze of glory. It was going to revolutionise the system. It ended up fading without a trace. But there was a doctor from New South Wales, and I cannot unfortunately remember his name, who went around the country. I listened to a talk that he gave, and he was talking about essentially what you're saying, different practitioners within the centre. He also said that they have a nurse see the patient first, and instead of the patient going to the consulting room, he could wander around with an iPad and go to see the patients after they've been checked for their blood pressure, their blood sugars, whatever it might be. And look, this is really very impressive. But it needs a certain, first of all, you need to have the space. Secondly, you need to have the resources. And third, it's almost a boutique type practice that when people are just as busy as they all are, there's also that issue of time to do it.
Correct. I think just take, for example, now the urgent care clinics. Okay, nurses triage, doctors see, GPs may not be the one. It could be a normal RMO doing that, and they have facilities like imaging, bloods, everything within that center, the urgent care clinics. I'm just thinking aloud, if this can be replicated to primary care across the board, would that make a difference?
The concept of the urgent care clinics is, again, it's been tried. I've seen these things so many times, Martin. Comes from having been in the system for a while. But unless you've got new or more doctors, then you're just moving them from point A to point B.
Correct.
And they're still going to see the same number of people. They might just see them at a different geographical location.
I totally agree with that. You're shifting the problem.
It's been estimated that the cost to the government of a person being seen in an urgent care clinic is something in the order of 5 to 6 times as much as them being seen in a general practice. Back in the 80s, there used to be a differential in the Medicare rebate for after hours, and that was then eliminated. There used to be a lot more after-hours care delivered in those days. And then the criticism was, well, some of this is routine, it's not really after hours, so we'll get rid of the whole thing. Well, system's never going to be perfect. But, yeah, it does come back to the geography. Like when Kevin Rudd launched the super clinics, yeah, great, fine.
It was
a building is never going to treat a person unless you've got the staff, and that's medical and nursing and receptionists, and you've just rearranged the pieces on the chessboard. You haven't actually created anything new.
I think you stated super clinics was a disaster. In fact, even the $38 million given by the state government for St. John of God to set up 4 centres.
Right.
Now, they were supposed to be bulk bill, and now they don't bulk bill anymore.
I presume because it's not viable for them.
It's not financially sustainable. And then after that was wasted, they started to look at urgent. Now, I agree with you. I'm also a skeptic of urgent care clinic. How long will that last for? What happens? Change of government? Would the funding still be there? Would it still be able to survive? I don't know. I think we need to find long-term solutions.
Yeah.
I, for once, believe that the government should fund more to primary care to create this environment of holistic care. Provide more resources to primary care. We need the primary care. Primary care is what sustains the future health of our society. And if primary care fails, we have problems. And urgent care, is it a stopgap measure? I do worry. I do know urgent care clinics cost millions of dollars. And it's going to continue to cost, and the rising cost has to be somehow managed. Perhaps we should have funded that to primary care. I don't know. At one point, I did think of that as well.
I think what you said in there, Martin, maybe primary care is the proverbial canary in the coal mine. And if it staggers and falls over, and there's just a couple of pointers in that direction, that will do damage to the entire system and necessarily impact the society. So we really, and I think part of it, when I look at it, is there's just no respect from anybody in government for GPs or general practice. Is my personal view. And I think that's sort of what we see, but that's just me. Look, this has been fantastic to hear your thoughts, Martin. Before we wrap up, any sort of closing thoughts or ideas for the listeners?
Yes. I mean, to be honest with you, I think it's a hard problem to resolve. It's many governments tried it. I mean, Liberals, Labour have tried their very best. We always have hope, okay? But the key factors or key constructs we need to worry about is the moral and ethical philosophy in this debate. Where do we go from there? Where is the equity, equality in the system? We always say a fair go to any Australian. What is a fair go? Do we, as doctors, as medical professionals, as practice owners, as governments, what's our duty to the society? Where do we draw the line? Is the government right or wrong? And I think the question about, many of my students in moral philosophy question me, is that right or is that wrong? It's not a question of right or wrong. What works? Yes. Every society is unique. Yeah. We cannot be
There's no one size fits all.
No, not at all. We cannot be like the UK. We cannot be like New Zealand. We are unique. We have our own set of health issues. We have our own set of population, vast areas, rural, remote. We have a lot of challenges in Australia. And I empathize with the health ministers in the state and the federal. There is no way they can resolve this problem. I don't think you or I would like to be in their shoes because where do you target limited resources? How do you target effectiveness, efficiency? With moral philosophy, we question what is moral to you may be immoral to the next person next to you. Exactly. One man's meat is another man's poison. Yeah. So where do we go with this? Frankly, I'm sure we'll never solve this problem for the next few decades. I think we'll be dead and gone. Our next generation will still be arguing about this. But I think in the long run, we look at a distant future and see if we can solve the problems. In my perspective, I always believe we have sustainable development goals of the UN, and we work towards making sure every healthcare is accessible and affordable. We have a duty to our fellow Australians to give them the best care that we can. And there are a lot of vulnerable people in our society. We just have to help them. And that is my final words, I think.
Yeah. And look, part of advancement is having discussions and throwing out ideas. And I think that's what we need more of in society, less censorship and more different ideas that we don't all have to agree with. Martin, it's been fantastic to have you on the show. Thank you so much for your time. And if you're agreeable, we'll get you back again for another chat.
Thank you so much, Dr. Joe, and I appreciate your time. At least we get to winch. I'm sure we can agree on that, which is good for society. Absolutely. Thank you.
Thanks for listening to Dr. Joe Unplugged. If you enjoyed this podcast, please subscribe, like, and share. You can also follow it on all the socials. There'll be new content uploaded each week.